We like to introduce the next speaker, Dr. Minh Tuấn, with the topic of endovascular intervention for post-thrombotic syndrome in patients with the mitral syndrome. Case report, please.
Well, good afternoon, professor and doctors. So I'm Dr. Tuấn from the AIR team, and today my topic will be about the endovascular management of post-thrombotic syndrome secondary to mitral syndrome. So we all know the post-thrombotic syndrome with severe complications of chronic DVTs, and it comes with venous chronic obstruction and atrophy of the veins and loss of vascular and perivascular inflammations. And the symptoms will be the lung pain, swelling, hyperpigmentations, loss of venous ulcers, and venous claudications. So that will cause the decrease of the limb functions and the patient quality of life. And the mitral syndrome is a common cause and the risk factors for DVTs. This is the length of the patients of post-traumatic syndrome. You can see there is severe lung swelling, loss of cutaneous hyperpigmentations, and loss of healed and unhealed venous ulcers. So the treatment will be the combinations of conservative therapies, anticoagulations, and endovascular treatment. And for endovascular treatment, we have the recanalizations, the thrombectomy maybe, or sometimes most of the time will be the reconstructions of angioplasty and stent placements. And the goal of the PTS treatment is to reduce the severities of PTS and the improvement of the patient quality of life. And this is the guidelines recently published. Mostly will come from the societies of the vascular surgeons, not us. And you can see that they are all recommended for iliac stenting for treatment of PTS. And last year, finally, SIR released a guideline that recommended iliac vein stenting, metallic stent stenting, for treating the chronic obstruction of the iliac vein. So that gives our IRs an official role in treating the post-traumatic syndrome, not an optional role like before. So our data is only 5 patients. It is a rare disease, and even more rare with the mitral syndrome. It is the rare of the rare, you know. So the 5 patients with lower extremity post-traumatic syndromes and mitral syndrome combination. And all the patients underwent the endovascular balloon angioplasty and stent placement. And our primary endpoint was the total recanalizations of all affected veins in the completion venogram. And the secondary endpoint was the improvement of the clinical symptoms, the Villeneuve score, and the color Doppler ultrasound. The primary patencies, as SIR recommended, was the duration from the first intervention until the first event of venous occlusion detected. Maybe in Vietnam, it's mostly in the color Doppler ultrasound and the CT. And the secondary patency was the duration from the re-intervention to the next event of venous occlusions. So the results, the most patients are female, the median age was 41, and the average time from the onset to intervention was 18 months. And the mean pre-intervention Villeneuve score were 18.4. The mean post-intervention Villeneuve score was 5.6, and our primary patency was 6.5 months. And 3 of the 5 patients had complete thrombosis and stent occlusions after 1 to 2 months, and they all had to undergo the re-interventions. And one of them had a failed re-intervention, and he continued to be treated with conservative and anticoagulation therapy. Let's go with the case. So the first case was a female patient with history of chronic DVT and mitral syndrome, came to us with limb swelling, venous claudications. Her Villeneuve score from the beginning was 8 points. So on the CT, you can see that there is mitral syndrome, the small and tiny left common iliac vein, the small inflow, and iliac vein chronic obstruction. This one is video doesn't work here. You can see it. This is the mitral syndrome, small and tiny left common iliac vein. Quite fast, right? So procedures, we went from the left femoral veins, some angiography, and we revealed the chronic occlusion of the iliac veins, the proximal segment of the femoral veins, quite hurtful. And we performed the recanalizations, the balloon angioplasty, stenting, thrombectomy. This is the initial venography, and it showed the chronic occlusion of the iliac vein, the proximal part of the femoral veins, loss of collateral. And we used the O35 guide wire for blunt recanalizations, just punching through the obstruction. And it failed, so we switched into the CTO technique, which we used the O14 and O18 guide wires. And after crossing the lesions, the obstructive lesions, we insert the low-profile balloons for pre-dilatations. and then exchange for a stiffer guide wire, bigger guide wire, and stronger balloon for complete dilatations of all affected veins, and then the iliac vein stenting. Well, after stenting, on the venogram we found some newly formed or even residual thrombus in the stent and in the treated segments of the iliac vein. So we decided to perform the thrombectomy, and after thrombectomy, the flow was quite acceptable, so we decided to stop. So both procedures, the patient showed some improvement of the symptoms, and the stent occlusion occurred after 1 month post-stenting, so she had to undergo recategorization, and her final Vedanta score was 3 points. The second case was a female patient, again came to us with left limb swelling. Well, on the CT, you can see that this is the maternal syndrome, loss of iliocaval, and phantom thrombus. You can see the thrombus in the IVC and even in the iliac veins, left iliac veins. So we decided to perform the IVC filter placement first, and then we performed the CDTs and the thrombectomy. We took out quite a lot of acute and subacute thrombus. 2 months later, the patient came back with us with limb swelling again and venous claudications. Her venous score at that time was about 6 points. So on venography, you can see that there is the chronic obstruction of femoral vein and iliac vein with loss of collateral. We decided to perform the balloon angioplasty in femoral vein and iliac veins, but these lesions just keep recoiling. So we decided to perform the stent placement in the iliac veins to prevent the veins from recoiling again and to keep the flow. Pro procedures, the patient showed good recovery. The symptom improvement is good too. And she continued treated with anticoagulation and stocking. After nearly 2 years, she came back to us to take the filter out, not the limb swelling again. And we decided to perform some venography to check the vein and the stent. And the venography showed good in-stent flow, good inflow, good outflow, and her final Vilanta score was about 2 points, just slightly swelling, heaviness in the left flank. So we can see that endovascular intervention now play an important role in the management of the PTS. And something that we should know about the post-thrombotic obstructive lesions, that they often extend for a long segment. They compose of dense fibrotic tissue, unlike the arterial plaque. And they involve for critical inflow and outflow veins, which makes them very less responsive to balloon angioplasty alone, and most of the time they will require stent placement. And for the stenting, the cell expandable stent are recommended by all of the guidelines due to the minimal shortening, good flexibility, and high resistive force. And for the stent to be potent for a long time, you have to provide an adequate inflow. Mostly the inflow must come from the deep vein, like the common femoral vein, the deep femoral vein, or the superficial femoral vein, and even the popliteal veins. And this aforementioned vein can be angioplasty or stenting to provide enough inflow for the iliac stent. So from our data, the endovascular intervention for post-thrombotic syndrome in the setting of maternal syndrome had a high preliminary technical success. The patency time is not long and associated with high rate of reinterventions. But the treating of PTS is not only endovascular treatment alone. It is the combinations of anticoagulations, compression stocking, rehab, and especially us, the IR. Thank you for listening.
So I have 2 questions for you. The first question is for first case in follow-up 1 month, you find out the reocclusion of the case. So do you find any cause for reocclusion for first case?
Yes.
The second question is for follow-up of the case or series, and do you using venoangiography by DSA or ultrasound?
Yes. With the first case, we found out the reason of the reocclusion was the inflow issue, because most of the patients came to us is with all of them have an extensive thrombus from the iliac vein to the femoral vein and the popliteal veins. And it's a very severe condition because, the venous stenting is very different from arterial stenting. In arterial stenting, the inflow is larger vessel with a higher velocity of flow. But the vein from the beginning, they have slow flow. And now with the thrombus and the damage of the thrombus with the vessel wall, the endothelial damage, they will cause the perfect condition for thrombus formation. And with the slow flow, with the endothelial damage, the stent was very easy to be clogged again with the thrombus. And this patient, that patient, her inflow is quite bad, but we still decide to perform the stent placement. And we're hoping after stent placement, there will be another collateral will diverse the flow into the stent for us. And for follow-up of the patients with the DVT like this, we will use the color Doppler ultrasound from the beginning because it is due to the financial problem, you know. But if the color Doppler ultrasound have some sign of the venous occlusion, then we will need a CTV to assess more, because you know the color Doppler ultrasound is not very good at assessing the flow in the iliac vein because it's like deep in the bodies. So the Doppler ultrasound only good at following up of the superficial veins like the deep femoral vein or the superficial femoral vein and the common femoral veins, but the deep iliac veins, common iliac veins or the external iliac vein, for example, is very hard. And sometimes it cannot be observed because due to the air from the colon. So the first choice of follow-up is the color Doppler ultrasound. And if the color Doppler ultrasound fails, we will need the CTV.
Sorry, one more question. What antiplatelet or anticoagulation do you use after stenting?
Well, we are radiologists, so it is really a great issue to us because our internists, they prefer the endosulfans, but we prefer the Lovenox post-stenting because it's very important. Well, the Lovenox is rarely used in most of the research and most of the guidelines, and it should be used after stenting as the literature. But in our facilities, the internists, doctors, they doesn't want to use it because it is take a lot of effort in injecting or in observation of the patients and high risk of complications. So that's why maybe one of the factors that make our stent occlusion rate so high due to the bad anticoagulation therapy.
I have a small question. What kind of stent you use for that patient?
Yeah, well, actually we would prefer the venous stent and with adequate diameters for stenting. But in our facilities, we can only use the biggest stent that we have. Mostly it will be the wall stent of the Boston, and the diameters for the PTS case were about 9 to 8 or 9 millimeters. It's quite small.
Because this patient is not the venous stent.
Yes, it is the arterial.
It is not the venous stent.
Yeah.
It's the causes of reobstruction. Because radial force is not enough, and it's cause of obstruction.
Well, yeah, that would be one of the cause of the venous obstruction, venous stent obstructions. But we had consult some doctor, and mostly we come from the inflow issue, I guess.
Okay, thank you.
Yeah.